in our communities to really feel more comfortable and confident coming in to get early mental health support. It's been amazing to see what the direct marketing has done in terms of reach there, the number of young people that have recognized Headspace nationally, 60%, almost 50% of families are aware of this is the place for their young people to go in and get help. It's a model that's been replicated now in a number of other countries, and we really want to be next in terms of making this happen. So at this point, we've had some funding and support from the Robert Wood Johnson Foundation to work on building this out. We're looking at trying to start 2 sites in Santa Clara County and have been talking with folks there, and then also would really like to partner with folks in San Mateo. We have some events coming up through the supervisors in Santa Clara County to maybe do this, and have been applying for an innovation grant within that county to get additional support. We've had community agencies that are anxious to provide some of these critical components as well. We've been grateful to meet with the folks from Peninsula and Sequoia Healthcare District here about potential partnerships, as well as with county partners as well in behavioral health, and are looking to see what we can put together through them and also through partnerships with private funders, because this really needs to be a public-private partnership effort to make these kinds of models happen. And we continue to work sort of nationally. There's a web link if you want to look at the program more. So I want to close just by inviting you to potentially come to our Adolescent Young Adult Mental Health Conference, August 5th and 6th, where we'll be talking about a number of these programs. A number of people in the audience are going to be speaking about their great work in schools, the wonderful things that are happening for our young people in a variety of programs. And we're really wanting to have specific programs for young people, for families, for educators, as well as clinicians and policymakers. So I hope you'll join us. So thank you. So pass your questions up front, and now I'm going to switch hats and introduce our next speaker. So I'm excited to be able to introduce Dr. Leanne Williams, my colleague from the Psychiatry Department at Stanford. Dr. Williams is the director of PanLab and the director of PTSD education at the Palo Alto Sierra Pacific MyRec, which is an integrated program for clinical care for veterans with dementia and PTSD. Dr. Williams' research programs are aimed at changing how we characterize people experiencing mental disorders, such as depression and anxiety. Her work is really to deconstruct diagnostic groups using brain imaging, physiological, behavioral, and genetic data to really characterize dysfunction at the individual person level and to identify biomarkers that will guide individual prognostic and treatment decisions in real-world clinical settings. Her research has contributed over so I know you'll be excited to hear from Dr. Williams. So thank you. Come on up.
Thank you so much, Steve. And thank you for the opportunity to speak here. It's a beautiful setting to be talking about this topic. And thank you to Chip for the invitation. You can probably tell from my mangled Californian accent that I am originally from Australia, so I'm very aware of the Headspace program and the origins of that. What I wanted to talk to you about today is what I envision as a future direction for mental health care, and one that will do what seems to be 2 important things. One is change the narrative as a way of addressing the stigma, and the other goal is to make better use of our existing treatments, and how do we, in our existing therapies, and how do we better target those therapies and treatments to each person's individual need, and at the same time realize that we need to consider the whole person. So it's unlikely one therapy or one treatment will be the only solution. What got me into this is I started life training as a clinical psychologist, and was talking to Eunice. One of my very first jobs actually was in Sydney in the 80s, and it was the time of deinstitutionalization. So this was when people who were in very long stay care in psychiatric hospitals were being moved into community settings. So the importance of a good home was really apparent from that work. So in the first role, there were people who'd been in hospital for 35 years or more, and when they moved into the community setting, we were working there as a team of psychologists, psychiatrists, social workers, advocates, 24 hours, and the issues that we faced were very different to what I'd been trained to think about. They were very pragmatic, they were about people's lives and all of the complexity. And just to share one example with you, there was many, but one that really stood out was a gentleman who dealt with the voices that he was hearing, which were constant, by holding the transistor radio he had to his ear on static between the radio stations. So the static actually helped calm down the experience of the voices. And that really struck me as saying we really don't have an understanding of where that's coming from, but it certainly tells us if we could understand more about the brain, we would understand the link between how our brain functions and what we actually experience. So that really led to my work, and from there did a PhD, and now I'm very fortunate to be a professor at Stanford in psychiatry with Steve. First, just want to acknowledge people that I will mention. I'll mention their names as we go through, so I want to acknowledge their important work. One of the studies I'll talk about is an international trial that I was running to try and understand the link between each person's brain and their genes, their own experience, and what antidepressant might work best for them. Thank you. And that's a study called the iSpot-D study. Can you hear me at the back? Thank you. So, as the way I think about it, we're in the midst of a paradigm shift, several paradigm shifts. One of them, though, is to do with how we're bringing neuroscience, very rapidly changing insights in neuroscience, into mental health and the care of mental health issues. So in a way, kind of shifting from thinking about psyche or our experience to how do we actually bridge this gap of what we experience and understanding the complexity of the brain, and what are the tools that we can bring to bear. So not the idea of replacing each individual person's own experience and individuality with only the brain, but how do we actually integrate this information. So the vision I have is, we could think of it in several ways. One way is to think about a personalized medicine for psychiatry, for mental health care. We could think of more precise ways to manage healthcare and the tools that we bring for understanding mental health in the same way that we do other areas of health. So this graphic I'll come back to, but the idea is currently the colours of people are all the different kinds of experiences we could have expressed as mental health, symptoms of mental health issues. And we don't have a good way of understanding how do we go from our individual experiences to the bottom row. What treatment is going to work best for me, or what combination of treatments depending where I am in my life and my experiences. So what we have that's exciting from the neuroscience is breakthroughs in this middle layer of actually understanding the complexity of the human brain as an intermediate step in understanding that link. And we think of these as large-scale neural circuits or large-scale brain circuits, and not so much different to thinking about circuits in other systems, just more complex. And we now have these imaging ways to image the brain in action that tell us about these circuits. What's relevant to thinking about mental health, the full spectrum of mental health, is that we finally have some information about very complex ways that the brain functions that explain experiences that previously didn't seem understandable in terms of the brain. So if someone says to us now, I'm experiencing a brain disorder, or I have a friend experiencing a brain disorder, we probably think of something like maybe Parkinson's disease, or maybe we think about Alzheimer's. We don't tend to think about a mental health issue. And my suggestion to you is that that's because we haven't sufficiently understood the complexity of the brain and the effects of our experience on it. And that's the landscape that's changing, so we have a new way, a new narrative to think about mental health issues. The two last points I think are very relevant to thinking about the future. If we can understand that brain complexity, we have a way to think about new ways to deliver healthcare and new tools for our therapists to use. Importantly, I think, and I experienced this in my research, each time we have someone participate in the research, we offer them the opportunity to get feedback from the research. And one of the most rewarding experiences has been the participants telling us and the therapists that it's changing the narrative. It's giving them a new way to explain their experience and a new way to think about, it's not my fault, or it's not because I'm morally weak or I'm not trying hard enough. It's like, I can try and I can do all these things to make it better, but I have a way to explain what's happening. So I think that has an impact on reducing stigma. So this is a kind of summary of where the research is at. I won't go through it in detail, but it is certainly available on the website for my research lab, and more than happy to share the details. In summary though, the idea, this is using example now for depression and anxiety, but because my interest is in how do we direct the research to important needs, I also study other areas, so look at psychosis, attention disorders and so on, but the furthest along that we are is really in depression and anxiety. So we could think about all the different ways that an individual, myself, others, family, people that you know might be experiencing depression, anxiety. The individual ways is coming down to essentially 8 different ways that these circuits of the brain might be disrupted. So let's just take one, the top left. I refer to it as rumination, which is the descriptive name that I give it, and it means basically worrying a lot, like the feeling of not really being able to control your worries about the future in particular. And what we see in the brain is that when the brain is normally resting, it has this triangular kind of pattern of the different regions that communicate with each other, expressed in blue. But for some people, that's overactive, so too much activity when the brain's otherwise should be at rest, and it creates this kind of looking too much maybe at your own negative thoughts, and that makes it very hard to do other things. It makes it very hard to focus, makes it hard to concentrate, can make it hard to sleep, and that pattern seems to respond really well to particular types of therapies and not others, for example. So that particular pattern doesn't necessarily do well on standard antidepressants. So that's one example. Another would be the one underneath it that I call anhedonia, is for people whose main experience is losing the ability to feel pleasure in activities that they've had before. And they tend to feel very slowed down and it's hard to move, so their movement's restricted and their feeling of positive experiences are restricted. And that's associated with their restriction in a different part of the brain. So they, in a sense, are expressed in different individual experiences. So just two examples, and I've color-coded them to represent these major circuits of the brain that we're identifying. So how might we think about this actually applied? Obviously the goal is how can we do better? How can we reduce stigma? How can we identify treatments? So let's think about an analogy. So in cardiology, for example, further along in the evolution of research and its application, but we can think about types of cardiac problem on the left, like an electrical circuit dysfunction, pumping, blood's not being pumped, different types, and then we can have tools to actually identify those types, different types of imaging, and that leads to different choices of treatment that are combinations of lifestyle and medication, surgery examples. So this is a kind of analogy to thinking where we could go with the research. I'd like to propose that definitely now's the right time to be doing this kind of research, but translating it so it doesn't stay in the lab, so prospective studies. I'll touch on data from a few studies. I'll keep it brief, but these examples come from first-degree relatives, so people that are well, but have a mother or father who's experienced depression, people who have a diagnosis of depression, a middle one, and then a new study we're doing at Stanford where we're taking everyone in regardless of diagnosis who's experiencing depression or anxiety. And we simply, relatively simple probes to put the brain through stress tests, so to speak, to make it activate these different circuits. So one way is to show faces of people, we can do different types of tasks, and you see very distinct patterns. So here's one example. These are people experiencing depression on first-line SSRI antidepressants, and you'll see, depending on the way your brain's functioning in this circuit, you will either respond or you won't respond. So, and the accuracy of actually predicting that is fairly high. So that's the potential for a brain scan that can tell us that separation. There's another indicator that will tell us whether you're likely to respond to a different type of antidepressant, not the first line, and that's even higher accuracy. Interestingly, people who are at risk but have not developed the illness actually will look more like the people with depression who don't respond. So we're getting an indicator of risk factors. Obviously, the brain's not everything, so we also need to think about these other levels: genetic risk, life events, and Steve touched on stress, which is very important. So let's look at a couple of examples. What we have found is that particularly traumatic events early in life, so emphasizing again the early life, will really affect whether you're likely to respond to treatment. So we see a frighteningly high level of early trauma in people with depression, so almost 4 times higher, and that's before the age of 17, but the main effect comes from when it's before 7. And this is the difference. So for kids that have experienced abuse, their likelihood of responding to a medication is hugely lower than people who haven't. So there's an opportunity for early intervention that will affect a later chance of responding. We also see this combination of effects. So experience of an early trauma will shift these brain circuits that we're looking at, and a combination will even more strongly give us a predictor of what treatment is going to do best. I'll very briefly touch on one example of how the genes can affect this, relevant to Steve's example. So there's one gene we studied, for example, that affects the mood chemical serotonin, and depending on what variant you have, and we all have variants, so 40% of us will have this S variant. And if you are exposed to childhood trauma, your chance of getting depression elevates, and that's the stress combination, gene stress combination Steve was highlighting. So again, an opportunity to intervene for people at risk. It will drive this brain circuit phenomenon I was talking about, so exacerbate the excessive activity of the brain. You see that in various regions. This is a quick snapshot of how we deliver these results back as feedback. And I want to finish a very quick snapshot. But really an idea of how can we think about moving this research actually into the hands of therapists, and how we can do it in a way that's reimbursable and can be managed time-wise, can create a new narrative. So maybe just in the last minute, a couple of case examples of what give us hope as the difference that it's made. So this is one fellow who took part in our research and had a lot of bad experiences failing on medications and ECT. And we found he had this type, this anhedonia type. And that suggested he wasn't going to respond to those other treatments, but we are finding a good response on other different treatments that target that brain circuit. So brain stimulation and a whole different type of class of medications. Another example from a woman who also didn't do well on standard SSRIs. She tried meditation and it didn't work, but it was in a quiet room. And we found she had this rumination type, the worrying, and that tells you a quiet room may be hard. It may exacerbate worries, a chance to reflect. So she's trying active walking to decompress, along with behavioural therapy. So I guess my last thought is, how can we make this a reality? How can we actually translate the research to the clinic and get this into action? So I look forward to working with you on that. Thank you.
Thank you, Dr. Williams. It's an amazing vision, and it's incredible the degree to which you're putting these pieces together. It's really very exciting work. So we're at the point where we are going to take about a 10-minute break. Please be sure, as you have questions, to write them down and send them to you. And we'll be back in 10 minutes. Don't go too far, because we're going to be gathering again really fairly quickly at this point. Thank you.